Hello everyone, this is Rosie Talaga with Becker's Healthcare. Thank you for joining us for today's webinar, CDI and AI at Cape Fear, an integrated blueprint for clinical excellence and revenue integrity. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we will have time at the end of the hour for a Q&A session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. Today's session is being recorded and it will be available after the event. You can use the same link that you used to log into today's webinar to access the recording later. If at any time you have any issues with audio or visuals, please try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to introduce today's speakers, Dan Bray, Corporate Clinical Documentation Integrity Manager at Cape Fear Valley Health, and Josh Amrhein, Business Manager of Revenue Integrity at Solventum. Thank you, Dan and Josh, for being here today, and I will now turn the floor over to Josh to get us started.
Thanks so much, Rosie. And as Rosie introduced ourselves, for today, we're really hoping to cover here how to operationalize AI across CDI, coding, and revenue integrity workflows, ways to improve your case mix index accuracy while easing clinician burden, how proactive safeguards can help prevent denials and revenue leakage, and tactics to break down silos and accelerate reimbursement. So to kick it off, I'm going to turn it over to Dan.
Hi, Josh. Thanks for the introductions. It's a pleasure being here today. I'm the Director of CDI at Cape Fear Valley Health System. We currently have about 8 hospitals, and we serve the 8 counties located in North Carolina in the Southeast region. Of those 8 hospitals, it's kind of diversified with the different type of practices that we also entail. We have one of the busiest EDs in North Carolina, but also one of the 10th busiest in the nation as well. We get pretty well busy with some of our workflows in the inpatient setting as well, because we are always at full capacity. We have no competitors in our area. Our nearest one is near Duke in the Raleigh area, which is about an hour and a half from us. So what we'd like to discuss today is talk about what the CDI transformation, how that is way we were before, why we changed, and what it took for us to collaborate with Solventum in getting the phenomenal results that we have achieved so far with that collaboration. So the CDI transformation, it was critically important that we show the patient care quality and the importance of how our health system functions and reports out to the community and also nationally. We were not doing as well as we should have been doing until we started working collaboratively with Solventum and got our workflows to be more effective and more streamlined. In the past, before I got here, which was about 9 years ago, there were about 5 CDIs who were homegrown, who did have some initial training about how to be a CDI. There was no oversight. There's not really much leadership that they could resource and reach out to provide better insights to how to be a CDI and what to do in reviewing a record and how their reviews would impact the health system and that patient quality of care. They were very siloed. There was not much interaction with the other ancillary departments like our coordination of care, utilization review, and quality, as well as coding. There was some minor interactions, but when we engaged Solventum, we realized that we needed to improve that working relationship and break down those silos with the other departments. The communication interdepartmentally, even among the CDI teams, was very limited because the leadership didn't have that oversight and gave them the attention that they needed to recognize where they needed to focus their energies on. With those 5 CDI, they really only got to about maybe 75% of just the Medicare population. Uh, there was education was very limited. The resources and the integration of the software did not fit well with the EMR that was currently in place at that time. And it was a hybrid system between paper and electronic. The CDI did actually go to the units and would try and find a spot on the unit to engage the physicians and get access to those paper records. And it was very challenging, especially when the paper record portion was somewhere else, like in the patient's room, or the provider had it somewhere, or even traveled with the patient to radiology or other departments in the health system. The resources to the providers was also very limited. There wasn't much education provided to them in what they needed to do and how they needed to document in the record. So you could probably imagine what it was really truly like to be siloed and not really truly be integrated with the health system and communicating with the ancillary departments, and also verifying, was the patient in the appropriate level of care for medical necessity. There were trends with denials that really weren't focused, and the mortality reviews with that severity and risk of mortality weren't as accurate and reflective of the illness of those patients being treated by our hospitalists in-house. The leadership at the time, from what was relayed to me, was the coding manager actually had oversight of all the coders and then also of the CDI. And so the CDI at the time felt that they weren't getting that attention and focus to learn where they needed to review the record and how to review the record, as well as our CFO at the time didn't really provide that much accountability and resource utilization to the CDI in getting them to be successful to where they need to be. So as part of the resource of the health system, they went out seeking for someone to come in and take ownership of the CDI program. So in the 9 years that I've been part of the CDI leadership, again, we started off with 5 CDIs, and we're now up to 22 CDI, and we review all payers at this time, rather than just focusing on our government payers. And that was part of the transition in the communication for that at-risk model we took with Solventum, and the collaboration in getting the revenue and the record to accurately reflect the quality, the resource utilization, the appropriate level of care for those patients while they were in-house for us. The Solventum did a overhaul and provided insight, especially with their background in putting systems in place across the country. They assisted with education, they provided mentoring and shadowing, and also made sure that we were following the appropriate guidelines for ACDIS and AHIMA for our query process, and also provided regular routine education on a weekly, monthly basis, and now we're actually on a quarterly basis during that transition that we have been with the at-risk model with Solventum. The software programs that we are currently utilizing have been awesome in the fact that now with the NLU process, it is engaging and providing evidence sheets for our team members to look at opportunities that they weren't always seeing during a true manual review. And we're getting to more records and coverage of our patient population. Initially, they were only doing about 75% of the Medicare population. Now doing all payers, we're up to about 90% review rate. Our query rate is about 65%, as well as our response rate from our providers is about 94%. Well, I'm sorry, it's 100% for our response rate, but our agree rate is about 94%. We have an awesome escalation process in place due to some collaboration with Solventum and putting some policies and procedures in engaging our physicians in real time during our escalation process when the queries are in place concurrently. And then also we convert those retrospectively and they become a deficiency for our providers. So that's why we have a 100% response rate. The staff for our CDI are more organized and follow the prioritization workflow that Solventum provides. And we also provide continuing education to our providers with a peer-to-peer that Solventum has provided for us as part of our at-risk model with them. We have also broken down those silos with our quality department and our coordination of care or utilization review and work very collaboratively with them in providing the geometric length of stay for every inpatient with the auto-suggested DRGs that the Solventum product provides for us. And we go and we validate those and update those auto-suggested DRGs for our providers, making sure that geometric length of stay is up to date for discharge planning for our utilization review team. The workflows are more streamlined. We utilize a prioritization workflow component where we prioritize based upon our payer sources, then also based upon if there's any type of CCs or surgical or MCC opportunities that are missed, that the AI component actually helps us look at and helps us prioritize those in our work list. Josh?
So I'm going to talk a little bit further about AI-enabled CDI and really having a vendor partner, and Dan touched a little bit on this already, having a vendor partner that's clinically focused and expert-driven is very essential. We know really the AI is the buzzword in, I think, the healthcare industry as a whole, but especially in the HIM, CDI, coding, revenue integrity departments. You know, there are, I would say that the field is very saturated with a lot of different vendors out there, obviously bringing similar things to the industry, but also at the same time, maybe the same things. But it's really important that as you're thinking of a vendor partner or a workflow to really enable, that it has experience behind it and that the vendor partner has that level of understanding. I think sometimes, you know, when I'm talking to customers, it is a little bit easy to get distracted with the next shiny object, but the next shiny object is not going to be maybe that's going to drive the best solid results. This CDI is I don't want to say isn't basic. It is very complex, and Dan will touch on that, especially in some of the results that they saw in their workflows. But it's very important that the vendor partner that's selected has that strong background for getting it right. And at the bottom of the slide here, you really see, I would say, four areas where a CDI solution is focused, and I would add a fifth one probably there. But obviously, reimbursement is a portion of that workflow. Quality and safety reporting is very important. I would say that, you know, over the years of my experience working with CDI customers and now revenue integrity customers, you know, quality and safety and the dabbling or the focus of those CDI programs has definitely increased. Risk adjustment, that obviously continues to be a hot topic, obviously on the outpatient side, but that also flows on the inpatient side now. So making sure that having a CDI solution that can capture that is essential. And then regulatory and compliance, from the Solventum end, that's something that we take very seriously on the regulatory and compliance end. So really making sure that you have a vendor partner that really does check all these boxes and has that level of understanding. And then the fifth one that I would add to that, and really where we are partnering with Cape Fear, is on the revenue integrity portion. And I do have a future slide coming up of really how that could blend into a CDI program and how this can really help to enhance some of those workflows. Dan touched a little bit on this related to prioritization, but having really an AI-powered solution that also has clinical focus behind it is very important. And the way that we have this slide broken down, I would say, is looking at the top, and you'll see it on the right-hand side where it says that financial opportunity, but looking at what are those auto-suggested DRGs, or where are those DRG opportunities, or those focused clinical populations that the CDI program really needs to focus on. We know as a vendor in our experiences that a lot of teams are being asked to do more with the same headcount that you have, or unfortunately with limited headcount. So we want to make sure that whatever is being prioritized for that end user obviously has the highest weight or that highest opportunity. And then if you continue to break it down even further, when you get out of, let's say, those financial opportunities, then you begin to move into those quality opportunities. So having those encounters reviewed that have, an SOI or an ROM impact. Looking at the length of stay, you'll see on a future slide that I have coming up when we talk around the denial data, length of stay becomes very important, because we know, again, that a lot of the encounters that are being reviewed are not those short encounters, but those short encounters are sometimes those that are carrying high denial dollars behind them. So I'll cover that in a future slide. And then really looking at maybe those lower priority cases, or having them not even really be part of the prioritization. The important part here is that as you're building out your workflows or your focused areas, there's multiple ways to really slice that onion. And maybe you want a certain parts of the department to focus on some of those certain DRGs, or some of those certain patient populations, or certain facilities. You'll see under the AI section there, that AI brain, it says focused auto-populated work lists. That's obviously very important. And then really getting that real-time prioritization, where based off of the changes in that encounter, that prioritization score is constantly being updated. Having, let's say, a batch update, or something that, or a process in place that isn't looking across the full encounter real time, might cause something to be missed. So having that real time intelligent prioritization, looking over that full encounter beyond just the provider documentation, but looking at what is being contained from a lab's standpoint. What are some of the radiology results? Looking at the medication administration record, really looking at that full picture and have that play a role is very important. And then the last piece that I would mention is really that denial risk. And I would say that that is a little bit, to a degree, of a mind shift that I think that we're seeing in the industry and working with CDI programs. There are revenue integrity programs out there. There's denial specialists out there, very retrospectively. So it's really getting that concurrent workflow and shifting it as far left as possible. And that far left as possible may be the CDI team, but being able to identify for that CDI end user, what is that denial risk? Maybe what's being identified isn't necessarily wholeheartedly the responsibility of that CDI team member, but through people, process, technology. Dan talked a little bit on their CDI transformation journey, but through people, process, technology, can a CDI end user tap on the shoulder of another team that says, hey, can we resolve this issue while this patient is still in a house? Save that retrospective work. And I'll cover that as well on a future slide. Enabled by advanced technologies, powering a unified workflow that closes the loop between clinical care and revenue integrity is obviously very important. There's a lot of pieces and parts called out on this slide. in how you can really enable your team members to really look at those cases or those encounters that have that highest opportunity. So using artificial intelligence and natural language understanding, I mentioned that, reasoning over the full encounter, and really getting that level of insight beyond just that provider documentation, really being able to identify where are those opportunities that maybe would have gone undisclosed or unnoticed. Looking at computer-assisted physician documentation or provider documentation, nudging that provider while they're doing their documentation real time to save them time on the back end, really getting that most complete and compliant encounter documentation at the time of that patient care to also help drive better quality and better patient care at the end of the day. AI-powered prioritization and evidence sheets. I talked a little bit about the prioritization on the previous slide. Dan talked a little bit about the evidence sheets in his previous slides, but really being able to identify for the CDI team what has been found is being compliantly documented within the encounter, but what is still missing that could help shift maybe some of those, may help shift to a different DRG, or maybe will help shift to a different length of stay and get a couple more days to help drive that better patient care. Auto-suggested DRGs, really using AI to reason over the encounter and help suggest should that working DRG, or what should that DRG be considered to be the working DRG. Automated impact. At that 2 slides ago, I talked at the very bottom about having that complex program and talking about reimbursement and quality and all the different other pieces there. Automated impact, when you think about it, is very complex. There's multiple different pieces that can play a role into how that impact is calculated. So having the ability to have a solution be able to automate that for you is very important to make sure also that something doesn't go miss. Streamlined query delivery and advanced query messenger, I would say go hand in hand. That, I would say, is probably something to consider as a positive impact or workflow impact on the provider end. We know that they're getting queries sometimes from multiple different methods of delivery, maybe from multiple different teams, but being able to streamline that process and then also having it go to their mobile device. I know if there's any physicians listening in, some may disagree with that, but we definitely have heard from customers and physicians where that is, I would say that is a positive thing. Having it on their mobile device, being able to answer it right then and there has obviously had positive impact. Advanced code sequencing, I'm sure for those on the HIM side or coding side that are listening to us, they know the top 25 slots are obviously the most important. But having that advanced code sequencing is obviously very important to make sure that all those concurrent working codes are falling appropriately in that code set so that when it goes off to billing, those top 25 codes are being used most effectively. And then high-powered analytics tracks trends and really be able to identify what are those operational, financial, and quality impacts to drive the next level outcomes. We're in the next couple slides, we are going to cover some of the data and some of the impact that Cape Fear's been able to see. So it's very important in having the ability for those high-powered real-time analytics. Talking a little bit about revenue integrity, and I mentioned it about how this really could help power a CDI workflow. We have this slide broken down, I would say, in 2 parts. The top part being the predict workflow, and the bottom part being a pre-bill workflow. So let's focus on the top part being the predict workflow. You'll see where it says the targeted end user or CDI encoders. So I mentioned where, taking it from the retrospective standpoint to more of a concurrent standpoint, or moving it as far left as possible, that's really where we want to be able to predict if a denial is going to happen and present an action to a coder, CDI, or clinician to prevent that denial from happening before coding actually happens. So, we want to be able to make sure that the claim is as clean as possible before it actually drops. And in using data based off of your billing practices, your payer practices, being able to say, hey, this same clinical representation, this same code set was used previously and a denial did come out of it, or you did have a DRG downgrade, or there was a take back at some point. Being able to predict that from happening, and then being able to say, hey, this is the action that should be considered or should be taken, is obviously where we want to be to save on that rework on the back end. Again, there may be parts and pieces that we call out into a workflow that isn't the responsibility of a CDI or coder. Maybe it is medical necessity that has to go to utilization review. That's great, but using a workflow and technology, can we capture that all while the patient is still in house? So thinking of getting from that retrospective space to really a concurrent space. Hopefully they're reducing the rework and really improving operational efficiency and then timeliness of the payment. That obviously is, from the vendor standpoint, that's important to make sure that you are getting, as a health system or a hospital, you're receiving the payment that you're expecting to really be able to help move that bottom line. And then focusing on inpatient, outpatient, ambulatory, and professional encounters, really in that predict workflow, again, concurrently. At the bottom section there, looking at the pre-bill workflow, the target end users here are really the coders and auditors. So at this point, coding has been complete, but let's see, give it one last review using AI to really help decrease the possibility of any additional revenue leakage. I'm looking at really where there needs to be maybe some additional clinical support put behind that DRG to mitigate DRG downgrades from happening. So really, we're looking at optimizing the inpatient revenue capture in this particular workflow, really focused on the inpatient side at this point. But this is really from a revenue integrity system solution workflow, breaking it down to predict, again, focusing more a little bit concurrently, CDI workflow to pre-bill, again, post-coding, more focused on the coder auditor type workflows. From here, we're going to jump into some results, and I'm going to start, before I pass it back to Dan, talking about the CDI results. I'm going to talk a little bit about the denial results and denial summary that we've been working on with Cape Fear here. And really, if you think about in the previous slides where I talked about prioritization and how that could play a role, some of the statistics that we saw here related to working with the Cape Fear data is really where we could have some further considerations, I would say, related to the workflow. So the one thing that I do want to call out is that this is just focused on mid-cycle denials. So obviously we're looking at those that we believe would have an action where there could be a concurrent action, I should say. So this isn't as whole looking at denial data, but really focusing on those mid-cycle denials. So if you break it down and look and think about the previous slides, specifically where I talked about prioritization and some of those enhanced workflows, we can take this data and then enhance the workflows a little bit further. So for example, if you look down to number 3, where it says select DRGs are 2 times greater than the overall denial rate. Well, if you look there at, let's say, the red blood cell disorders, or the COPD, or the poisoning, well, we talked a little bit about how we could use prioritization for focused DRGs or evidence sheets for focused clinical conditions. We want to be able to take these results and be able to enhance those workflows even further, so that those encounters that have, let's say, these type of issues or these DRGs really are, if there is still an opportunity, they're floating to the top so that those opportunities are being resolved as fast as possible. If you look at number 4, CDS review encounters have about a 6.2% denial rate. But I talked a little bit about length of stay. And one of the things that we saw here, and this isn't just here at Cape Fear in particular, where we've seen across other customers' data, is that those short length of stays, those encounters that really do not get a CDI review, have a higher denial rate. So looking at those 1 or 2 length of stays, it's not going to make sense to have every one of those encounters reviewed, but pairing that up with the DRG, can we then have those encounters reviewed by CDI through prioritization? So looking at that length of stay is obviously very important. And then the last one being, at least in particular with Cape Fear data, those encounters that were not reviewed by a CDI obviously had a higher denial dollar rate than those that did. So that's a positive there to say, okay, your CDIs that were reviewing encounters, obviously they weren't hitting nearly the denial dollar rate as those that were going unreviewed. So again, sort of taking that number 5 and peeling that onion back a little bit further as well to say, okay, is there something more that we can do here related to the DRGs or to how we are having prioritization configured? So taking a little bit deeper dive on that number 5. So from here, I'm going to toss it back to Dan to review some of his CDI statistics.
Thanks, Josh. And as you guys probably have not realized, but I'm not one for public speaking. But I will tell you, I am very passionate about the data that we've gotten with the collaboration with Solventum. It has been phenomenal in the returns that we're seeing, not only with our case mix index, but also with our mortality and severity of illness that have improved with that collaboration and the training and with our providers as well as with our CDI. The first slide here is our Medicare, managed Medicare ratio of observed to expected. Now, as you can see, it's definitely, improved. I mean, the lower the numbers, the better the results are for the observed over the expected. And I'm hoping that, as we go through the rest of the data, that you can see that information, as well as that how important that having that streamlined workflow, that education, those resources available for you in enhancing your CDI program, as well as providing that information to your providers and letting them know that that documentation is extremely important, and not only for your patients in that continuum of care, but also with that impact to the health system and the revenue enhancement that occurs with that as well. Our overall case mix index, you can see how it has drastically improved for our overall and for year to date and the interim periods that it's showing for the improvement. For our case mix index for Hoke Hospital, which is one of the 8 hospitals that we are part of this collaboration with Solventum. This is also with our Hoke Hospital for our Medicare managed products for our mortality rate variance, and it's definitely improved as well. The numbers are definitely reflective of that collaboration with our providers and teaching them that the documentation is improving that severity and our risk of mortality for our facilities. As well as with Hoke Hospital, we're also showing that ratio observed to expected mortality in regard to the observed over expected. Harnett Hospital, which is another one of our facilities that we have as part of our health system, our case mix index is drastically improving there with that collaboration. And the education with our CDIs and showing that those risk adjusters, those HCCs, Alex Hausers, and those severity markers improve that documentation, which enhances our DRGs, our geometric length of stay improvements, as well as that case mix index improvement. Anything below the 0 baseline for your mortality scores is awesome. We did have an interim increase from October 24 to December 24, but that's only a 3-month period compared to the other markers here. But it's still showing that our observed over expected mortality variance is extremely awesome. I'm going to say that. Because of the collaboration and interactions with our physicians and that peer-to-peer conversations that we're having with Solventum's physicians, with our providers here at Cape Fear, in doing the education sessions and showing them the data that their documentation is helping with our overall metrics and improvement with those scores, as well as our quality metrics as well. Harnett Hospital, again, is another way of viewing our data for the observed over expected. This is an overall sketch of what it was like when we first started with Solventum in September 21, and initially when we first started with 19 October of 2020, is we actually integrated with a new EMR at that time as well. And then we collaborated with Solventum in our at-risk model. And we did have a plateau, but once we did further education with our team, as well as got more staff, which was extremely important to get to the cases that we needed to get to. You can see that we went from a 1.58 to a 1.8195 CMI, which is a drastic improvement. I know it doesn't seem much, but it really is a drastic improvement over, a 4 to 5 year time period. And that at-risk model that we had with Solventum was very beneficial in the fact that if we didn't reach certain metrics during the time period while we did the collaboration, then we wouldn't have had to have paid because of the at-risk model. The information that Solventum provides to our executives during our executive reports has been very reflective of how the physicians have interacted with the response rates, creating our escalation processes, that collaboration we now have with our coding and our utilization review teams, and making sure that the documentation reflects the appropriate medical necessity so that it reduces our denials there. As well as reduces our denials for our top DRGs, which is sepsis, respiratory failure. We have shown that having the education to our physicians is improving our denial reduction, if that makes sense, and helping us get an improvement with our case mix index. The data, I mean, I can go on and on about how the data is being reflective of that collaboration and making sure that we're getting the record to show the continuity of care, that collaboration interdepartmentally in the communication tool with that record is extremely paramount. And especially if we have to refer a patient to another health system, we know that our record stands alone and accurately reflects everything that we did for that patient. Let's see. Our mortality score for the main campus observed or expected is showing, awesome improvements in how we're increasing the severity, that risk, the Ellis Hausers, the HCCs, the risk adjusters, and without that collaboration we've had with Solventum in educating the team in how they need to look at a record, as well as having the software highlight and point that out during our evidence sheets, and helping us generate those queries to our providers, making sure that those clinical indicators are there and pointing out to the providers that, okay, your documentation is lacking, there's ambiguity, there's inconsistencies there, that we need to engage you in getting improvement with our documentation. I will say, at first there was some resistance from our providers, but once we've shown them that data, they have actually been more engaged and are seeking more data to saying, okay, how can I improve? There's some competition between the different providers and the hospitalists and saying, okay, well, my improvement is this compared to yours. So it's nice to see that they're doing that among the team and saying, okay, this education has been very beneficial, and we're showing the improvements with their data, as well as our quality metrics. We're showing improvements with our star ratings, and Leapfrog, which has been very integral to the community and also providing resources to our community as well. Josh?
So in summary, obviously Dan just reviewed his CDI results. I touched a little bit on the denial results and how to use that data, but strong results require, obviously education, motivated and resilient staff. Dan talked about that at the very beginning of where they were and the journey that they went through. He just talked a little bit about engaged and involved providers and provider leadership. That obviously is very important to make sure that you have those appropriate providers at the table whenever decisions are being made, especially those that are going to impact their workflow, so that you can get their input rather than them always sort of digging their heels in the ground and not coming along for the change. Committed and responsive leadership at all level is obviously very important. I can honestly say it's been a pleasure working with Dan. I was on site there right before Christmas and had the opportunity to meet with his CFO and CRO. So, as he mentioned, they're at the table, they're involved in our meetings, they're giving input. So having that responsive leadership at all levels is very important. Collaboration across the organization. I think we talked a little bit on that as to how to break down the silos, but then also thinking outside the box of how through using people, process, technology, workflows can get a little bit further enhanced. Having the tools and resources to identify improvements and opportunities is obviously important. AI is playing a very large role in our industry and enhancing workflows, but having those tools and resources available to help identify those improvements will also help to ensure the strong results and success. So with that, I thank everyone for their time. And Rosie, I will turn it back over to you for Q&A.
Thank you so much, Dan and Josh, for such a wonderful presentation. And now we will get into the Q&A. So audience members, please feel free to continue submitting your questions via the Q&A box on your screen. And now we will get started with the first question. So first, we have someone asking, can you talk about the education you did for your providers in person, email, webinar, or something else?
So it was actually in person, and we do continue to do that. As part of that work that we've done with Solventum, they did provide a physician as part of that at-risk model who came on site and did education sessions with our physicians. That provider pulled our data and actually discussed that information with our hospitalists. And we actually did all service lines, from our hospitalists to our cardiologists to our OBGYN. It was all of our service lines were involved in that peer-to-peer education. And we're now still continuing that education, but it's now on an annual basis. We are doing monthly educations, at least my team is, with our hospitalists monthly, and providing them with a data and also case studies of where we're seeing the denials and what we can do to improve that, as well as concurrent documentation, because when we do the case studies with them, we're actually doing real cases for those providers so they can actually reflect on that information and show them, okay, you've got this documented. We queried because of this, and this was the outcome in improving that geometric length of stay for our patients.
Thank you so much for breaking that down. For another question, we have somewhat related to how you're working with the teams. It's for teams that are worried about change fatigue. What kept staff motivated and resilient through the transition?
I'm sorry, I don't mean to laugh at that, but I will say we have a unique acronym here at Cape Fear. There's those that are BD, before Dan, which were those 5 CDIs, and then we have those that are AD, after Dan. So the BDs will always say that when Dan came, there's always been changes. And I will say even the ADs after Dan have all been very flexible and have been accommodating and realized that these changes have been beneficial to them as well as to the health system. I cannot say enough about my CDI team and how well they work together. and want to do what's right for our patients. Even though we're not at the bedside, we are still patient advocates and make sure that that documentation is reflecting appropriately. And that's why we engage our physicians, not only via the query format, but we'll pick up the phone or utilize our EMR and engage them that way. I will hear sometimes every now and then, well, Dan is making another change, but they do recognize that that change is beneficial for them in streamlining our workflows. And I seek out their input. I mean, we can't be successful in our CDI transformation if we don't engage our CDI and ask them, well, what will work for you? What is better for you in getting to review these records? And having them to be part of that actually helps them with that, fatigue, so to speak. And that communication and transparency is very paramount in your success.
Absolutely. Understanding that why and having the collaborative approach is so important. Our next question is wondering, is the entire process embedded in Solventum, or is there a second vendor involved?
So it's all embedded in the Solventum product with our evidence sheets, the prioritization workflow. As Josh was mentioning earlier about the revenue integrity solutions, that is also going to be part of the Solventum product. That's part of the evidence sheets in helping our team be prompted for those potential propensities for denial. Josh, did you have any input on that?
Nope, you answered it great.
Oh, cool. Thanks.
Perfect. So for our next question, it's referencing something you specifically discussed in the presentation when you talked about the staffing model that increased from 5 CDI to 20 plus. They're asking, is that just for one facility? If so, how large is that facility? Is CDI centralized for all your 11 hospital locations?
So it is, my CDI team reviews all of the hospitals and they all work remotely. We utilize our prioritization work list in our Solventum product that prioritizes all of our facilities and all of our patients at those facilities. With it being remote, I'm kind of old school in some aspects. I like being on campus, and I actually do come on campus every day so that I can go and engage our physicians. So if there's any challenges with, they're not being knights in the sand by not answering a query, or they're asking why they're being queried, I can go to the floor and engage those providers. And that I will also go to our other facilities and also engage those physicians at that time as well. So the reason we increased our CDI staff was due to the at-risk model that we had with Solventum, recognizing the fact that we could not be successful with the limited number of CDIs we had at that time, which were 5. So a staffing analysis was done with the number of discharges that we do in our health system and the different hospitals and the patient acuities, and recognized that we needed to add additional staff. We have also grown in our health system during that time period by adding new towers and adding additional beds. So unfortunately, the slide I presented for Cape Fear showing 600, we actually have up to 800 beds now. So we've had to have add additional staff to make sure that we're getting to those reviews. And this is only the adult acute inpatients. We're not looking now at our pediatrics or our psychiatric or our LTAC facilities at this time. I will say future state, we will be looking at our pediatric and adolescents and OB patients going forward. So that centralization for us has worked well because it gets to all of our hospitals, and getting those reviews and having that prioritization work list has been very helpful to make sure that we're getting to those cases in a timely fashion and looking at the right cases at the right time. so to speak.
Wonderful. Thank you so much. For our next question, kind of two combined that are both asking about your query response process and response rate. So can you further describe your 100% query response rate and the deficiencies created? More specifically asking, how did you get the response rate to be so effective?
Well, we hold our physicians accountable, and that was very helpful for Solventum to help us with a policy and procedure. The CDI staff query both concurrent and retrospective. So as part of our response rate, we have an escalation process that once a query is generated within 24 hours, if the provider doesn't respond, then we will send a message to that provider saying, hey, you have an outstanding query. If the provider does not respond in an additional 24 hours for a total of 48 hours, then I'm added to that conversation. And I don't want to toot my own horn, but usually when they see my name on that message, they do respond because they know I will come find them on the floor to get them to respond, and they don't want to have that face-to-face conversation. However, if the patient gets discharged prior to that query getting answered, we will convert that to a retrospective coding query, and then that becomes a deficiency for that record. And if that provider does not answer that query, then they will actually get suspended for not answering the deficiency on that record. So that's part of our query process in our 100% response rate.
Thank you so much. That's a great answer to leave off on for today. I want to thank everyone in the audience for such thoughtful questions. We will send out the slides and answer any unanswered questions after the webinar. I want to give a big thank you to Dan and Josh for such an excellent presentation, thoughtful responses to the Q&A, as well as Solventum for sponsoring today's webinar. Thank you again, everyone, for joining us, and I hope you have a wonderful rest of your day.